Okay, thanks very much. I'm very anxious now about that little bell going off. So, is that a 1 minute or a 2 minute warning?
I can give
That's end.
I can give you a minute.
Okay, give me 1 minute. Just that'd be great. Yeah.
The second bell means the rapture has begun.
Okay. I'm ready. Right. Before I start, I'll just hand these out because I brought them to hand out at the end. Could you just circulate those? Thanks very much. Okay, my name's John Laugharne, as I've been introduced. I'm from UWA School of Psychiatry, and I work also at Fremantle Hospital. As I've only have 10 minutes, I'm going to keep fairly focused. I'm not going to talk about any research as such, and in fact, I did the first slide or two really refers to what David's already talked about, which is his work. But I always mention this in talks normally because I don't normally have David here. I have to introduce the context of what we've done. Essentially, the clinical guidelines that we've put together, which were published late last year, which some of you will already have seen in some form or another, were the result of the Health Right project that we just heard about. One of the outcomes from the Health Right project was to develop some clinical guidelines to help clinicians do a better job in terms of physical health care of consumers. And Anne was working away on various other aspects of the project, and I got involved in this particular aspect as a sort of spin-off from Health Right, if you like. And I'd like to give full credit to Sue Stanley, who's the first author on the guidelines. Sue has been the prime mover in putting these guidelines together with sort of support and help from myself. So over the last, and what was great was that the money was there to employ Sue just to work on this, and it took 18 months of her working full-time on this project to put together what we ended up with. So these things don't come easily, and they don't come cheaply. I guess that's the point, and that's why it takes time to get things moving along. But I think what we ended up with was something very useful, and I'm now trying to sell it to my colleagues, which it's interesting how, having done all the work, you'd think that people would be very pleased to have these kinds of guidelines. But unfortunately, as is the harsh reality of these situations, a lot of my colleagues just balk at what is being suggested. In other words, that they do a much more comprehensive job of physical assessment and care of patients. But I understand why they're balking. I mean, I think I've got to be realistic about this. As a psychiatrist myself for some years now, I understand that they're under the pump doing the main part of their job, if you like, and they see this as an extra. That how on earth are we going to find time to do all this? Well, there are answers to that question, but I do think that this is the time for services, for government and for leaders to be thinking really hard about how to make this work, this sort of more joined up approach, more integrated approach, the sort of thing that David's just been mentioning. How do we actually make this work? Because it's not there is no simple solution. If there was a simple solution, we'd have put it in place years ago, I think. So I think this whole issue is now very much on the agenda, but it's really important that we think hard and that we think creatively how we're going to improve outcomes, because at the end of the day, what we have to do is show that anything that we put in place is going to improve outcomes for patients in terms of physical health. So that if David and colleagues were to do this study that he's talked about, which was published in 2001, so it's 10 years since that came out. I think if you did it today, there wouldn't be a huge difference, to be absolutely honest with you. I'd like to think if we did it in another 5 or 10 years, that there would be a big difference, and that's what we've got to be working towards. So what we put together was a sort of a package which has several key elements to it. And what we decided to focus on, having looked at all the literature and looked at what else was out there, were these 5 main dimensions. Medication effects, which are talked about quite a lot, physical disorders that people might have, as well as their mental disorder, lifestyle factors, alcohol and drug use issues. And we also put in a section on psychosocial supports, because there's good evidence in the research that people who have better psychosocial supports don't only have better mental health, they also have better physical health. And that, I think there's a logic to that that can be seen. In fact, there was a very interesting study that came out last year in the States that showed that essentially psychosocial support systems, and however you measure that, there are ways of doing it, are as important as things like smoking. In fact, statistically, I think it came out as more important than smoking or alcohol use in terms of someone's overall physical health. That's a phenomenal, there's a massive research, there's a meta-analysis actually. So I think that's something that gets underestimated, although probably in mental health we're more aware of the importance of psychosocial support systems, or just support systems, than people are in general medicine. That's probably a little hard to read, but this is how we structured the whole package. It's all colour-coded, and it covers all those areas I've just mentioned in some detail. But it basically comes down to a handbook for the clinicians and an assessment book for community workers. And I'll show you those in a second. And then all the information can be collated onto standardised screening forms. The idea being that services can use this in an integrated way, and that all the information is collected in one place. I think if we just did that in mental health services, it would be wonderful. So there's a number of components. And for those who haven't seen the package, I'll show you. There's a main report which contains all the background information, which is probably not, that's really there for those who really want to go into a bit more detail about where all the facts come from. There's a wall chart which we put all around our hospital, all around Alma Street in Fremantle, which is the metabolic syndrome algorithm. That's where I started. Anna Waterous and I published that in the Medical Journal of Australia a couple of years ago. And that was really our kickstart to try and think about how we could help our colleagues do a better job of thinking about metabolic syndrome. And metabolic syndrome is a key, one of the key things we have to be thinking about when we think about physical health in mental illness. I haven't put all the slides up on it, but to put it bluntly, about 25% of the general population have metabolic syndrome, which means they are at about 3 times the risk of getting diabetes and heart attacks as anybody else. You can double that in the mental health population. So approximately half of people with psychiatric disorders have metabolic syndrome, and they're at substantially increased risk for heart attacks and strokes and diabetes. And that's why, that's one of the core reasons why the statistics that David presented look so bad. There's also this, which is the booklet I'm trying to sell to my colleagues. This is for doctors, essentially. It's got all the information on medications, how they affect your physical health, what tests doctors should be doing, and it's got all the information on metabolic syndrome and weight and how that should be monitored, how to do it, how to record it systematically, body mass index if you want to do that. It's really an attempt to bring together all the information that a psychiatrist or a GP needs to know about this subject, and they can sit on their desk, or if they've got big pockets in their pocket. So that's the idea of that one. And then there's this assessment book, which we hope can be used by anyone in the mental health team, or it could also be used in community services. Community workers could use it. And essentially it's a systematic way of recording information with a consumer in respect to all the key areas. So it goes through exercise and diet, oral and dental health, smoking, which we've talked about already. There's a sexual activity survey, which can be gone through when it's appropriate. There's an alcohol and drug section, and so on. And so this is something I think it's systematic. It uses short but standardised ways of recording that information that can be monitored over time, and that's the key thing. Okay, time is very short. That's the wall chart. The key things that you're measuring are waist circumference, blood pressure, lipids like cholesterol, and blood sugar. That's for doctors to remind them how to go about doing that. Okay. So, bearing in mind I've only got a minute left, what I really want to do is mention what I've handed out to you. The latest thing we're doing now, and we're almost there, is we're producing a consumer handbook that will end up looking similar to the doctor's handbook. The consumers that we've been talking with have suggested to us that they'd like a leaflet about the handbook, and so that's the intro leaflet that's gone round. The actual handbook, we're just going through the last draft, should be ready in the next few weeks to be printed, and it'll end up in this kind of format. The difference is the information is more geared for consumers rather than for doctors, but all the key information is still in there, and there's diary space in there. So there's room for a consumer, if they want to record blood test results, weight changes, and so on and so forth, all the things that might be useful for someone, and we're also going to produce a carer's version of that as well. So the idea is to supplement the package, which is basically up till now aimed at the clinical teams, with tools that the consumer can use and can drive these things forward, and take this to appointments with caseworkers and clinicians and so on. So it's a way of, I think, creating some empowerment in this whole situation. So I'll leave it there. I know I'm out of time, but thank you very much for your time. Cheers. Oh, sorry. I've always finished. We're actually out of hard copies. We've spent all our budget in regards to this. It's now really over to services to produce the materials that they need. But if anyone's interested, this is the website. You can download all this material from our website for free, and you can print it off if you wish. So I'll just leave that up for a moment if you want to jot that down. Thanks.
Thank you.